After the examination, we do some imaging. We check for drug levels if the patient is non-epileptic and is taking medications, if he is adherent to his medications, or if his levels are low. We check for prolactin, which differentiates to us a true seizure from a pseudo seizure. Usually a true psychomotor seizure will be associated with a rise in prolactin. We check CSF for possible infection, especially in children with febrile seizures, and we check for genetics in children with family history of epilepsy. So the patient collapse, what is the cause? There is transient loss of consciousness. Is it due to acute illness? Is it a syncopal episode? Or is it a seizure? Is it associated with hypoglycemia, intoxication, etc.? Total loss of consciousness alone is never a transient ischemic attack. And as we mentioned yesterday when we talked about the vascular disease of the brain, transient ischemic attack gives focal findings. Total loss of consciousness is generalized decrease in function, either due to abnormal neuronal activity or due to lack of supply of blood and nutrients to the brain, such as in hypotension. So after the history, we need eyewitness. We check for cardiovascular and neurological examination if the patient has any arrhythmias. We check for lying and standing blood pressure, because patients who have difficulty in maintaining the proper blood pressure when they stand up, we call that orthostatic hypotension, may be predisposed to syncope. And we do a 12-lead electrocardiogram to make sure that there is no cardiac problems. And then if we encounter a patient on the street having generalized tonic-clonic seizure, the first thing is to assure the safety of the scene. That means that the patient is falling and thrashing on the ground. We put him in a comfortable position. We put away anything that may move and may fall over him and injure him. If trauma is not suspected, we place him in the recovery position. And as we know, recovery position is to put the patient on his side and to put his head close to the floor, where if he has any salivation, it will flow out of his mouth. And to protect the head and limbs from injury, and we follow the ABC protocol, which is airway, breathing, and circulation. So we maintain the airway, we suction as needed, we administer oxygen, and we monitor the cardiorespiratory status. Well, here are the metabolic abnormalities that can cause seizure: hyponatremia, hyperkalemia, or hypercalcemia, hypoglycemia, or hyperthyroidism. All of these can cause seizures or may exacerbate epilepsy. Again, talking about the investigations, we did the routine investigations, we do the neuroimaging. Any person over 25 years of age or more and have the first seizure in life must have imaging, because most of the idiopathic epilepsies happen before 25 years of age. After 25 years of age, it's usually a focal epilepsy, and we should know what the reason for it is. It tumor, metastasis, vascular lesion, and so on. Patients with focal epilepsy, irrespective of age, should have imaging. And we do specialized neuropsychological investigations. Sometimes if the first EEG does not show us a focus, and we are suspecting that this is a focal seizure, we do what we call a sleep-deprived EEG. Sleep deprivation is an activation method that we use to bring out abnormalities in the electroencephalogram that are otherwise not seen. The electroencephalogram that we do usually outside the EEG, outside the seizure, is what we call Inter-Actal Electroencephalogram. And again, we are talking about a paroxysmal event. And who knows that during the time that the electrodes were on the brain, this paroxysmal event decided not to happen. So we try to give it more chance to happen by doing a sleep-deprived EEG, or we put the patient in a monitoring unit, and we do video EEG monitoring for a prolonged period of time, waiting for a seizure or a behavioral abnormality to occur, and associating that with what happens in the electroencephalogram during that time. So the advanced investigation in intractable focal epilepsy, we do neuropsychology, we do semi-invasive or invasive EEG recording, where we place electrodes on the surface of the brain or in the depth of the brain. So sometimes we do positron emission tomography. Positron emission tomography is a metabolic test where we inject, for example, the most frequently used radio tracer is a glucose with a radio tracer that emits positrons. And then we measure the amount of consumption of this glucose or concentration of this positron emitting glucose in the cortex or in the brain cells. And that tells us if there is an area of abnormal activity. Or we do what we call single photon emission computed tomography, where during a seizure, where we see the area of activity. What are the diagnostic findings? By clinical examination, it's frequently normal, unless we see some body asymmetry in patients who have congenital abnormality in one hemisphere. There might be hemihypoplasia of his hands. One hand may be smaller than the other, or genetic stigmata, such as what happens with tuberous sclerosis and so on. We check prolactin level within 10 to 20 minutes of a generalized tonic-clonic seizure, may be raised by 5 to 30 times over the baseline. We checked CSF. Pleocytosis may happen in any normal seizure, but it is rarely over 10. EEG, the inter-ictal may be normal or may show us generalized spike wave focal spikes, and we do the imaging if it localizes a lesion. This is the diagnostic framework that is suggested by the International League Against Epilepsy. And we, first of all, we check for comorbidities, then we determine if the seizure type is focal, generalized, or unknown, or then we determine what the subtype of that, and then we look for epileptic syndrome, and we check for the etiology on this side. The EEG abnormalities that we may find: background abnormality, there might be significant asymmetry, or it might be completely normal. Significant asymmetry, there might be some focal slowing or generalized slowing inappropriate to the state of wakefulness of the person or to his age. Inter-ictal abnormalities, which means that the spikes that happen and don't lead to visible seizures. There might be spikes, there might be sharp waves, there might be spike wave complexes. And these abnormalities may be focal, may be lateralized, or may be generalized in electroencephalogram. This is recording for an inter-ictal left temporal sharp waves, and the temporal sharp waves is seen over here and over here. And one is on the right side, one on the left side. This is the left, this is the right. So we can see the abnormal discharges. This is a patient with partial seizure of left temporal origin. This is inter-ictal in a patient with generalized polyspike and complexes. As you can see, the spikes are multiple, and then it is followed by a slow wave. spikes are multiple and followed by a slow wave. This is an idiopathic generalized epilepsy. Differential diagnosis contains syncope, metabolic, migraine, sleep disorders. We talked about that before. Now we go to the psychogenic non-epileptic seizures. About 10 to 45% of those who are referred because their doctor could not control their spells, 10 to 50% of them have psychogenic non-epileptic seizures, and that's the cause of their persistence, because we are treating with anti-epileptic medications, and the problem is psychogenic. The psychiatric mechanism may be a conversion reaction, maybe a dissociation mechanism. There is common association with physical, emotional, or sexual abuse. There is no obvious EEG correlation between the seizure. That's why those patients are admitted to epilepsy monitoring unit, and we wait for the seizures to happen while the electrodes are on the head. And when they happen, we look at the EEG and it is normal. And the diagnosis can be complicated. The majority of simple partial seizures have no EEG correlation sometimes because they are coming from foci that are deep. They do not reflect on the electrodes that are placed on the scalp. And frontal lobe seizures may have unusual semiology, not very well correlated with what we see on the electroencephalogram. But these are rare things, and only specialists can decide on that. So in psychogenic non-epileptic seizure, there are some features that suggest that this is a non-epileptic seizure. If there is thrashing, and thrashing means that there are movements that are not rhythmic. They are just movements of very chaotic movement, or struggling, or crying. He may be crying. Pelvic thrusting is a movement that is not seen in normal epilepsy. It's seen with non-epileptic seizure. Side to side rolling, either the head or the body, or wild movement. Or we may have preserved consciousness with bilateral tonic or clonic movements. The person may have the movements, but then when you speak to him, if there is bilateral tonic clonic movement, he should not be able to respond. If you speak to him and he will say yes, then that is a non-epileptic seizure. And lack of post-ictal confusion is non-epileptic seizure, and post-ictal crying or shouting is suggestive of a non-epileptic seizure. Now we come to treatment. What is the goal of treatment? Either to eliminate or reduce the seizure frequency and to minimize the side effect of treatment because he will be getting it for life, and to assist the patient in achieving as normal as possible life activity. Non-drug treatment, we tell the patient he should have regular sleep at regular hours, adequate sleep. Lack of sleep is an activating procedure that may cause activation in the electrical activity of the brain and is recorded on EEG, or activating the seizure activity manifested by seizures. Avoidance of alcohol and stimulants such as caffeine and so on. If the patient knows a seizure is precipitated by, for example, some seizures are precipitated by flickering light, he should avoid flickering lights, and to reduce stress. There is a list of anti-epileptic medications. I think you will be exposed to it in the pharmacology course. I'm not going to go through it in very details, but you give the patient medications and the patient may not get controlled. Either he is not taking them correctly, or he's being sleep deprived, and that happens sometimes to students during examinations, or he's maybe going through stress, or his temperature is high and fever stimulates epilepsy, or there is variation in medication effectiveness because they have been stored for a long time, or there might be a hormonal fluctuations, and it is well known that there might be some catamenial change in the control of epilepsy in females, hypoglycemia, dehydration, alcohol, drug abuse, or exposure to triggers such as flashing light. We would like for a person with epilepsy to live as normal life as possible. Seizure control usually considered the most important measure for quality of life. Complete seizure freedom has much greater effect on health-related quality of life measure than simple reduced frequency. Some people say, okay, he used to have 10 seizures per month, now he's having 2. Well, 2 is too much. Depression has greater adverse effects, so it needs to be treated separately, and drug side effects and unemployment may also reduce the quality of life. Depression in epilepsy, it happens in about 1/3 of patients with epilepsy. It happens in 1/4 of patients with asthma, and usually in controls, it's about 10%. It reduces quality of life and increases the use of medical resources. Death from epilepsy, standardized mortality ratio may be increased in patients with epilepsy, even if there is no underlying illness such as a brain tumor or vascular lesion in the brain. There is marked increase in sudden unexplained death. This is a phenomena that is known in the literature as SUDEP, sudden unexplained death in epilepsy. It is related usually to generalized tonic-clonic seizures in patients who require more than 2 anti-epileptic drugs. And when we talk about drug resistance epilepsy, the definition is failure of informative trial of 2 well-tolerated medication chosen and used by anti-epileptic schedule to achieve the sustained seizure freedom. Why do they fail? About 30% of patients may not respond to treatment. It is not a license for complete control. About 10% of patients with good initial anti-epileptic drug response may cease to respond. Either there might be some drug interaction, he may incidentally take another medication that will reduce the blood level of his medication, or he takes another medication that induces enzymes that eat up the anti-epileptic medication that he's taking, or there might be some tolerance to the anti-epileptic drugs. And the body has the characteristic of adaptation. And if he is exposed to a certain thing, a drug or a stimulus for a long period of time, he may get adapted to it by reducing the response to it. So the receptors on the cells may be less responding to the medication, or the channels may change their number on the cells in order to avoid the effect of an anti-epileptic drug that attacks the channels. Sometimes we have to resort to other methods such as the ketogenic diet. The ketogenic diet is now fashionable for weight loss. It causes some changes in the chemistry in the body, and it is usually substitute carbohydrate with fats. And the ketogenic diet has 85% fat, only 5% carb, and 10% protein. What it does, it increases certain chemicals such as acetone, aspartate, GABA, unsaturated fatty acids, and so on. And these might have a sedating function over the brain, especially the tricarboxylate tricarboxylic acid cycle, which is necessary for generating brain waves and generating epileptic activity. What are the side effects of ketogenic diet? Constipation. It slows weight gain, especially if we give it to youngsters whom we are hoping to have a normal growth. It may predispose to illness when the patient gets ill with fever. It may predispose to vitamin deficiency if there is no supplementation to the water-soluble vitamins. It may lead to renal stones by increasing oxalate secretion. It may impair the height and weight growth of children. It may cause increase in lipids because it depends on lipids. And it causes a feeling of nausea that probably part of it leading to weight loss. So intractable epilepsy, either caused by the lesion when there is mesial temporal sclerosis or malformation, or the illness itself, the recurrent seizures, or the predicament. There is a social predicament with intractable epilepsy, psychological and economical. How do we approach it? Either by surgical focal resection, or by hemispherectomy, or by callosotomy. All of these are neurosurgical procedures, or by inserting devices that stimulate certain areas of the brain. And we decide for surgery only when other treatments had been unsuccessful. So failure of treatment or for failure of anti-epileptic drug treatment is necessary. And we should be able to identify a focus that is leading to seizures. And third, the area of the brain involved by the focus can be safely removed. It doesn't contain important functions, significant functions. If we remove it, it will result in significant deficit. Brain stimulation rarely can be resorted to by vagus nerve stimulation or transcranial magnetic stimulation or intracranial stimulation by inserting electrodes for deep brain stimulation. This is the vagus nerve stimulator, and maybe also activated by an external magnet. Vagus nerve stimulation requires surgery, but the surgery is extracranial. The electrodes are placed around the carotid or around the vagus nerve that runs with the carotid, and effects broadly comparable to other anti-epileptic drug trials. Very rare that patients get seizure-free with it, and it is considered when there is no chance for resection of a lesion that is causing the abnormalities. This is the transcranial magnetic stimulator. There are some risks for brain stimulation, which you don't have, you just have to have an idea about it, but it is in the realm of specialty for neurosurgery and neurology. Just a few words about status epilepticus. It is more than 10 minutes of continuous seizure activity or 2 or more sequential seizures without full recovery in between. It's a condition when there is no return to normality between the seizures for over 30 minutes, maybe life-threatening, and it should be treated immediately in an emergency room, and treatment with anti-epileptic drug intravenously as soon as possible. And what we use benzodiazepines such as Valium or Ativan. We use phenytoin because it is intravenous. It has an intravenous form. We use valproate because it has an intravenous form. We use levetiracetam because it has an intravenous form. Other anti-epileptic medication that has no intravenous formulation is not used, like Tegretol, like carbamazepine, like topiramate, and so on. If there is no response, then we go to general anesthesia with either thiopentone or propofol in very refractory status epilepticus. I think this is the last slide. I'll be happy to hear any questions. Any questions?
Doctor, there's one question in the chat. What is genetic stigmata?
Okay. Genetic stigmata. Stigma is something that characterizes a person. Now, stigma usually is something that is used in a negative way. For example, if one has a character that is, or he belongs to a certain group of people, we call it he's stigmatized by that group of people. So stigma, that is the meaning of stigma in general. Stigma in Arabic is wasma. Genetic stigmata are the characteristics of or the features of a certain genetic disease. In epilepsy, for example, it is associated tuberous sclerosis is associated with epilepsy. Now, the stigmata of tuberous sclerosis are several. There are some facial small tumors that are stigma. There are stigma for that disease. There is achromatic spots that we call it the ash leaf spots that can be seen on the skin. Similarly, in neurofibromatosis, we have the café au lait spots. These are the stigmata of neurofibromatosis. So the stigmata are the features that are characteristic for a certain genetic disease.